Looking at health, we focused on a situational analysis of the sector, considered the various challenges limiting health service delivery, and proposed a number of policy options that could help address the challenges identified. In terms of a legal background, healthcare is an essential human right guaranteed by the Constitution of Kenya. Specifically, Article 43 of the Constitution provides that every person has the right to the highest attainable standard of health, including the right to healthcare services. Article 27 further prohibits the state from discriminating directly or indirectly against any person on any grounds, including health status. Besides the Constitution, health policy has its sources in a number of domestic and international legal instruments. By virtue of Article 26 of the Constitution, any treaty or convention ratified by Kenya forms part of the laws of the country. And for that reason, one of the international legal sources of health policy is the ICESCR, which is the International Covenant on Economic, Social, and Cultural Rights. It provides for the distinct components that determine access to health. We also have the Sustainable Development Goals, specifically SDG 3, that calls upon states to ensure healthy lives and promote well-being for all at all ages. Domestically, we have a number of statutes and policy guidelines regulating various aspects of the health sector, including human resources norms and standards and the health sector strategic investment plan. Going into the state of play, health has consistently been listed as one of the key priority areas for government under the program-based budgets over the last couple of years. The health sector national government allocation for the financial year 2016-17 was about 60.3 billion. That was out of a 2.47 trillion overall budget. This represents under 3% of the overall budget available to ministries, departments, and other agencies. Looking at that, we found that is below the 15% recommended minimum under the Abuja Declaration. In this current financial year, health had an overall allocation of 61.4 billion annual budget. This again represents merely 2.6%, way below the 15% recommendation under the Abuja Declaration that I've just referred to. Health insurance for the elderly and persons with disabilities was given as a separate allocation to about 300 million, again well below the 500 million recommendation under the Health Sector Working Group's recommendation. We also had another allocation to free maternal health care going to about 4.3 billion, and this has been the same over the last 2 financial years. Within the the county government budgets, health as well did not meet the 15% allocation threshold. A few counties did meet this requirement, but a lot still needs to be done to get to financing. Looking at the identified challenges within the sector, the first major challenge was on access to healthcare facilities. Now, the distinct components of accessibility to health are non-discrimination, physical accessibility, and economic accessibility, which is basically affordability. Looking at economic accessibility, we found that Kenya is yet to establish effective healthcare policies to address the costs, insurance policies, and healthcare cover. No proper guidelines so far have been set to facilitate affordability of health services. In terms of physical accessibility, we found that health facilities must be physically available for the population to access healthcare services. But only 63% of Kenyans have access to government health services that are located within an hour of their homes. That implies that the rest of the 37% actually have to travel this hour in order to access a government health facility. More than half of the counties in the country have fewer than 2 health facilities serving 10,000 people and fewer than 4.2 facilities accessible per 100 square kilometers. Densely populated areas such as Mombasa and Nairobi seemed to have more facilities per 100 square kilometers, but in terms of the populations that live in these places, the facilities were barely enough to accommodate those populations. Marsabit, Tana River, and Isiolo, on the other hand, had fewer health facilities per 100 square kilometers, but in terms of the spread of population, they had above average numbers of health facilities per 10,000 people. This suggests obviously that the counties may have a sufficient number of facilities for the population, but patients have to travel long distances to reach this. The counties with the fewest facilities per 100 square kilometers that were identified were Tana River, Kilifi, Mandera, Turkana, Wajir, Narok, and Bomet. People seeking health in these counties are inconvenienced by travel, time, and distance to the facilities. Kenya's health policy failed to provide specific details councils on how to establish interventions for key marginalized groups, for example, persons with disability. We contrasted this with the situation in India that has a very specific policy in terms of access to healthcare facilities by persons with disability. For this, we found that there is need for clear policy on enhancing healthcare access to PWDs. The second issue that we considered was on maternal health care, and we found that many facilities in the country and other low-income countries lack essential resources for maternal health services. Many of the facilities in the country function without basic infrastructure such as electricity, clean water, and most do not even have the capacity to perform cesarean section surgeries. Access to skilled delivery was a particular challenge, and we found that overall only 44% of births in the country are delivered under the supervision of a skilled birth attendant, below the target of 90% of deliveries being undertaken by skilled birth attendants. We found that there were serious inequities in terms of maternal health care, and this obviously led to inequities in maternal and newborn health outcomes, as illustrated by the fact that the poorest counties in Kenya have the highest maternal mortality ratios. 90% of births were registered in health facilities. That was nationally. However, Marsabit, Tana River, and Wajir counties recorded relatively high rates of over 40% of births registered at home. In June 2013, government initiated a policy of free maternal health care in all public facilities. We found that this policy led to an increased burden on health professionals, which was not matched with adequate increases in staffing. Underfunding of the policy also led to shortage in terms of supplies and equipment. The other challenge we found in the sector was on management of healthcare facilities in the country. We found that effective management includes setting sound policies and ensuring their implementation and clearly defined performance management systems. It would entail proper accountability and creating processes and incentives, defining roles, and hiring and motivating staff. The biggest issue around management of healthcare facilities was around accountability. We found that poor management of the Kenyan healthcare sector causes an annual loss of over 5 billion Kenya shillings to the country's economy. Now, the challenge of governance in the sector undermines effective, efficient, and timely health service delivery. Corruption specifically and inefficiency has been fueled by reluctance of both levels of government to be transparent and accountable to each other and to the citizens and the public. The financial year 2013-2014, a number of ministries, departments, and other agencies failed to avail documents to the Auditor General to support various expenditure totaling to about 66.7 billion. Of this, the Ministry of Health alone had unsupported expenditure totaling about 22.5 billion. This represents about 33% of all the unsupported expenditure for that financial year. We found that per the research, Sub-Saharan African region had the lowest management ratio in the world in terms of health services. Skill deficit has drastic ramifications on the improvement of health programs in the country. To address this, we found that government should accelerate discussions and implementation of public-private partnership initiatives for creation of sustainable models for healthcare financing. In terms of solutions for the issue around economic accessibility, our proposal was that it can be assured by making healthcare as well as services relating to the underlying determinants of health, such as safe, potable and drinking water and adequate sanitation facilities affordable to all, including the disadvantaged groups. Proposals that we had was for the promotion and the development of policies and legislation that protect the rights of all vulnerable groups. We need to make sure that there is sufficient oversight and regulation in both public and private healthcare facilities. On the question of accountability, given that one sector accounts for over 30% of the losses that are reported by the Office of the Auditor General, we proposed a need to enhance the oversight mechanisms in the country, the need for the various institutions tasked with looking at corruption and addressing the issues related to corruption. They need to tighten their mechanisms available and take serious action on all the responsible parties. On the maternal health care program, government can improve the implementation of the free maternal services policy by increasing the supplies available, increasing the number of staff involved involved in implementation, training opportunities for staff, improving their working environment and provision of incentives to the staff responsible, and a reduction in the number of working hours for the involved medical personnel. In terms of a conclusion, we found that to fully implement the constitutional requirements on health, we need to have a serious investment in a strong primary healthcare system. The government ought to accelerate discussions and implementation of public-private partnership initiatives for creation of sustainable models for healthcare financing to achieve universal health coverage. Lastly, the country should promote and develop policies and legislation that protect the rights of all vulnerable groups and make sure that there is sufficient oversight and regulation in both public and private health.